Thank you very much. It's a pleasure to speak with you this morning. And I'm going to talk about stroke prevention and atrial fibrillation. And as Dr. Piazza mentioned, I'm going to focus particularly on the morbidity and mortality of the disease. And I've spoken to many of you in this room over the years, and we've really focused on anticoagulation primarily for stroke prevention. I'm going to start off there because that still remains pivotal in preventing death and long-term morbidity in patients with atrial fibrillation. But then I'm going to shift and say that's really only part of the story with these patients, and we do need to think more broadly outside of giving them a blood thinner. And these are my relevant disclosures. And so obviously atrial fibrillation is incredibly important because really atrial fibrillation, along with heart failure and certainly diabetes, are really the three epidemics not only of cardiovascular disease but of medicine in general. And atrial fibrillation is rapidly increasing in this country and through countries throughout the world. There's like a 25 or 30% increase in the incidence of atrial fibrillation in almost every region of the world you look at. And with that is a concomitant increase in both mortality and morbidity, whether you're in a developed country such as ours or developing countries throughout the world. Now, when patients develop atrial fibrillation, you could sort of divide them into two broad categories of complications. They often present symptomatically not feeling well, mostly due to the rapid heart rate, and they might present to your office or the emergency department with fatigue, shortness of breath, palpitations, and even heart failure. And we know atrial fibrillation and heart failure are really common cousins. In fact, if you take patients with very symptomatic heart failure, class 3 or class 4, about 50% of those patients will also have atrial fibrillation or will develop it shortly. Most of our focus, though, after initially treating their rate and potentially entertaining some rhythm control strategies, is about the more serious complications of atrial fibrillation, which are cardioembolic disease. And that manifests mostly with stroke because most of the blood volume that leaves the left ventricle, the biggest consumer is your brain. So if there's an embolus in your atria and then your ventricle, unfortunately the brain is the first place that embolus will find. But of course, it could bypass the brain and lead to a systemic embolism, which also has a lot of mortality and morbidity associated with it. So this is obviously the dreaded complication where we see a clot in the left atrial appendage, and the worry is that clot will embolize and cause a stroke. And we know strokes from atrial fibrillation are the most devastating strokes that we encounter in clinical practice. Greater than 20% of them are fatal. In fact, in some series, it's almost a third. And 50% of the patients who survive will have some sort of permanent neurologic disability. So these are the types of strokes that you most want to avoid. They are very infrequently small strokes that patients recover from. But beyond, obviously, the stroke aspect, and clearly we don't want patients dying of a fatal cardioembolic stroke, is there are long-term consequences with respect to patients' cognitive ability and their desire to live independently. And these are very interesting studies that actually come from about 32,000 patients in angiotensin receptor blocker trials, but they very nicely categorize patients' baseline mental status and then followed them over several years. And what they noticed is patients with atrial fibrillation, which you can see here at baseline versus no atrial fibrillation, and patients with persistent atrial fibrillation, that if you look at different outcomes, whether it's a dementia or loss of independent living, even if you adjust for all other factors, there seems to be a 30 to 50% increased risk in either developing dementia or loss of independence and requiring admission for sort of long-term care. So that's a pretty substantial increase in risk. And obviously, some of this was due to patients suffering a devastating stroke that was clinically avert. But what's interesting is these results are pretty consistent even in patients who don't have a diagnosis of a clinical stroke. They come, they didn't present with paralysis or difficulty with speech or language comprehension. So clearly, this disease, and not only for stroke itself, but it's very important in that often these patients will progress to cognitive impairment and dementia over time. So clearly, preventing stroke, even small strokes that are not clinically overt, is obviously an important part of preventing vascular dementia. How do we establish whether people warrant anticoagulation to prevent the morbidity and mortality of stroke? Well, that's fairly straightforward now. Use of the CHADS-VASc score, and these are your risks per year in patients who you don't anticoagulate. Now, some of these numbers don't look so impressive. You know, we anticoagulate everyone with a CHADS-2 score of 2 or higher, and you say, well, this is about 1 or 2% per year. But remember, that's per year. And so that's like playing Russian roulette every year. If that patient survives 10 years, that's a substantial increase in risk. Think about it. We give statins to people whose 10-year risk is only about a 7.5%. And obviously, I think the guidelines will continue as the anticoagulants become safer to really anticoagulate lower risk patients, even with a CHADS-VASc score of 1. And I think it does matter which CHADS-VASc score you get the 1 point in. Not all 1s are created equal. Certainly age is the biggest driver of stroke. So if a patient is 65 years or older, regardless if they have any other medical comorbidities, I'd advocate them being anticoagulated. And just very briefly, obviously, our options to prevent stroke, fortunately, we're very lucky, is that we still have warfarin, and we've been using that for over half a century, and that's because warfarin's highly effective in reducing stroke by 64%, so it's a remarkably effective drug. There was a great desire to replace it because this, along with insulin, are probably the 2 most dangerous drugs we use in clinical practice, and now we heard from Sam in the VT space, but the NOACs obviously have been studied in 4 seminal phase 3 trials for stroke prevention atrial fibrillation, over 72,000 patients, and they're just as good as warfarin in preventing ischemic stroke. They're far safer with respect to warfarin for hemorrhagic stroke and intracranial hemorrhage in general, with 50% reductions in bleeding in the brain, and they tend to cause less major bleeding in general. But most importantly, compared to warfarin, there's actually a 10% mortality reduction. That's very consistent, actually, across the 4 NOACs. So these drugs, compared to warfarin, people tend to live longer. And it's very interesting, you know, why are they living longer on NOACs compared to warfarin? Well, we know whether you use warfarin or a NOAC, if you prevent strokes by 70 to 80%, people in general are going to live much longer with anticoagulants, about 30 to 40% longer, because they're having less strokes. But if warfarin and the NOACs are fairly similar with respect to ischemic strokes, why are the NOACs preferentially compared to warfarin for an even further reduction in mortality? And a lot of that actually has to do with the safety of NOACs. This is from work that my colleague Bob Giuliano did. And if you look at the 4 most common types of death in a clinical trial for atrial fibrillation with an anticoagulant, they're sudden death, fatal heart failure or shock, fatal ischemic stroke, or fatal bleeding. And this is for edoxaban compared to warfarin, and there's, although numerically less with edoxaban in these 3 groups, actually statistically, the only difference in death in these patients is actually in fatal bleeding. And so the mortality benefit of the NOACs are really because they're so much safer, people actually bleed to death less frequently. But it's not only fatal bleeding, which is pretty obvious bleeding. Someone has an intracranial hemorrhage, they herniate and unfortunately expire, or someone exsanguinates the large amount of their blood volume. But we know bleeding is bad for you in general, and bleeding can actually contribute to death directly, but not due to bleed. An example is someone has a serious bleed, ends up in the intensive care unit, develops a ventilator-associated pneumonia, and dies 30 days later. Now, they died of an infection, but I think everyone would argue if they didn't have a serious bleed, they would have never ended up in the intensive care unit. They never would have had a ventilator-associated pneumonia. So the mortality of the benefit of the NOACs compared to warfarin is really driven by the fact that they are far safer with respect to warfarin, particularly for serious bleeding. So that's a strong advocation of why for many patients, if not most, the NOACs should be a preferred agent. But if you start to look beyond stroke and beyond the fact that the NOACs cause less bleeding when you're trying to prevent stroke, there's an interesting part of this narrative that's not really the whole story of what's happening when we think about mortality in patients with atrial fibrillation. And this is studies of a cohort of insulin-detected atrial fibrillation patients. And what we find is that in patients with atrial fibrillation, they still have strokes. And a lot of people will think that's due to a therapeutic failure of their NOAC or potentially warfarin, but that's not actually true. If you look at these patients who have a atrial fibrillation, and they either have treatment here or no atrial fibrillation versus those who are untreated, you see in patients on an anticoagulant compared to patients with no atrial fibrillation, they actually still have a stroke rate of about 1.5 to 2% per year. And so these patients on an anticoagulant still have strokes of 1 to 2% per year, but that's the same as patients who don't have atrial fibrillation. So most of the strokes that are occurring in people on an anticoagulant are actually not cardioembolic stroke. These patients are in their 70s and 80s, and they're still having strokes from other mechanisms that are not necessarily reduced from anticoagulation. So it's not really a failure of therapy. But what's probably more surprising is over here on the right panel, is that if you look at patients without atrial fibrillation, this is their mortality rate. These are non-anticoagulated patients, obviously much higher, because these patients with atrial fibrillation aren't getting any stroke protection, and a third of them are dying from fatal strokes. But even patients that you're appropriately treating with an anticoagulant, their death rate is higher than these patients, and it's not due to loss of protection from stroke. So these patients are dying at a higher rate from a non-cardioembolic type of disease. And so the AF mortality certainly is dramatically reduced with anticoagulation, but there's a residual risk of all-cause death that's probably not related to stroke and not related to anticoagulation. So what are these patients dying of? Well, there's some interesting data that actually comes out of the clinical trials, and what's very nice about these large clinical trials is obviously we get new drugs out of them, and that's the reason why the companies pay almost $1 billion to conduct these trials. But they're actually a tremendous resource for us to learn much more about the disease and try to sort out how to better care for these patients. And this is from a meta-analysis of the 4 trials that actually shows if you look at anticoagulated patients, regardless of whether on warfarin or one of the new drugs, actually stroke and bleeding, which are important, is around 10% of the total amount of deaths these patients will suffer over the first 5 years. Most of the death is cardiac death, not related to stroke, or other types of non-vascular death, which is very interesting. What are all these cardiac deaths that these patients with atrial fibrillation are having? So if we look at specific causes of cardiovascular death, and this comes out of another trial, the RELY trial with dabigatran, the direct thrombin inhibitor, we see that cardiac death is very frequent, and in anticoagulated patients, actually the rates of fatal stroke or even fatal hemorrhagic stroke or hemorrhage are very low. So look at all of this residual risk of cardiac death. Some of the strongest predictors, if you look at what's driving this very significant increased risk, are some of the things you might expect. Patients who have heart failure, who have prior MI and coronary disease, and you see a 3-fold or 2-fold increase in risk. So clearly, patients with atrial fibrillation are at an increased risk of dying from other non-stroke related death, particularly if they have other medical comorbidities. Now, one of the things that I think is important to further delve into is any of this excess risk potentially modifiable? Because it's one thing to say we've identified a risk, and clearly that's important, but I think what patients and physicians want to know is there something, once we identify these high risks, and atrial fibrillation is either contributing to this increased risk in mortality or is a marker for some other disease process that we need to find out more about, but only if there's something to do about that increased risk. And this is another interesting analysis that we did from one of the NOAC trials that looked, even if you go beyond the fact that patients with atrial fibrillation, once you control their stroke risk, they're at risk of cardiac death, but what type of cardiac death in particular are they at risk for? And actually, the most common type of cardiac death they seem to experience is sudden cardiac death. So these are patients who, in a trial, were either completely well within 1 hour of dying, or last witnessed to be totally well within 24 hours and then are discovered dead. And then we see that sudden cardiac death is very common, and alarmingly, 93% of the sudden cardiac deaths in the largest of the 4 trials occurred out of the hospital, and 66% were not preceded by any symptoms. So this is really sort of a sentinel sign in these databases that there's obviously a lot going on with these patients, that you can't just check a box that you've prescribed an anticoagulant and think you've done their job. These patients are at very high risk of bad things happening to them. What was interesting about the sudden cardiac death, at least in this analysis, some of this was actually modifiable. If you looked at what were the biggest drivers of this increased risk, it was actually medication use. Two particular medications. One, if you look at these highest risk patients on the top, you see their event rate are much, much higher than the reference. And these patients were on DIG, and they were not taking a beta blocker. And then if you're on one or the other, there's an intermediate risk. So clearly patients who are on digoxin, even if you try to adjust for all the reasons why you would or not prescribe digoxin, it seems to be associated, not just in this study, but in several others, with an increase in sudden cardiac death. Some of that is modified by also the use of a beta blocker. So clearly this data seems to support we should be sure these patients are on a beta blocker, and we should avoid DIG if at all possible. You know, the mechanisms underlying these aren't totally well established, but I think this serves as really the springboard, is that there's a lot going on in these patients, particularly with regards to non-stroke mortality. The most common type of death is sudden cardiac death, and we need better markers to identify which patients are at risk and what are the things we can do to modify this risk. So to conclude, ischemic stroke is certainly the most important thing you need to address in patients with atrial fibrillation, because if you don't anticoagulate a patient, this is what they're going to die from. It's often fatal, or it leads to vascular dementia or loss of independence. So I am totally on board with the initial focus being anticoagulation, which is the thing that you will do that will most lower their long-term risk of both mortality and morbidity. But once you do that at your first visit, you know, think about which agent you're using. And not only will reducing stroke be an important part, and both are equally as good, the vitamin K antagonist or the NOACs, but remember, safety is important because serious bleeding leads to increased mortality and morbidity as well. And if cost is not an issue, really the NOACs should be preferable, because not only do you get that ischemic reduction, but they're far safer with respect to serious bleeding. But once you do that, unfortunately, these patients are at very high residual risk of dying from other things than stroke or bleeding from an anticoagulant. In particular, if you look at the types of death, as I mentioned, sudden cardiac death and heart failure seem to be big drivers in this population. And so I think we can't view these patients in a silo, and clearly we need multidimensional management that includes taking care of their coronary disease and heart failure and optimizing that medical therapy, because it seems if you have heart failure and atrial fibrillation, you do much worse with respect to your heart failure-related mortality than if you just had heart failure alone. But clearly we need more research to figure out why atrial fibrillation patients seem to be at such a pointed increased risk of having non-stroke related deaths. So this is really just the beginning of that research that we really only learned about actually from doing trials of anticoagulants. So it's one of the stories, I think, that we learned so much from these clinical trials beyond the initial purpose of the clinical trial. So hopefully more to come. And happy to take any questions.